I'm very happy now to introduce our next speakers who will engage in a fireside chat about chronic illness, disability, intersectionality, and justice. The chat will be hosted by Kate Nicholson, the founder and executive director of National Pain Advocacy Center. Kate is a civil rights attorney and a nationally recognized expert on the Americans with Disabilities Act. Joining her are Ola Ojewumi, an activist, writer, speaker, and nonprofit founder. She's a double organ transplant and cancer survivor, person living with chronic pain, like many of us here. Among many things, Ola advised the Obama administration on policies to advance the lives of people living with disabilities. We also have Charis Hill, an award-winning queer disabled chronic disease advocate, writer, speaker, and model, whose story has been featured in dozens of publications and media outlets. They're involved in national and international advocacy and are the co-founder of #HighRiskCovid-19. And Lindsay Baran, a research director at the University of Chicago in the Healthcare Evaluation Department, whose work focuses on health equity, stakeholder engagement, disability, accessibility, and program evaluation. To see all their full bios, click on speakers on the left side of feed. So thanks everyone for joining us here today, and I'll now turn it over to Kate.
Hi, everyone. We are so happy to be here today to be part of this conference of people with lived and life experience, and also to celebrate the successful launch of Pain Canada this year, which is a wonderful thing as well. We are your neighbors to the south. We are all coming from the United States, and we're all members of the National Pain Advocacy Center. You also heard earlier today from another of our board members, Dawn Gibson, who talked about creating inclusive chronic illness spaces. And today we're going to talk about our own experiences, our own lived experience, how that led us into advocacy, but really focus on framing pain, understanding pain as an intersectional disability, justice, and rights issue. And justice and rights are a little bit different, and some of us are going to address that today. But pain is chief cause of disability globally and in the US. And yet it rarely is identified in the strategic plans of traditional disability rights and equity groups. At the same time, a lot of chronic illness groups don't really see themselves aligned with disability, justice, and rights. But I think it's a really important lens for people living with pain. So today you're going to hear from a variety of people from the National Pain Advocacy Center. We are an organization run by and for people with lived experience. We advocate for the health and human rights of people living with pain. And I am the executive director. Ola, who you'll hear from soon, is one of our board members. Charis is one of our standout members of our Community Leadership Council, which is our group of people with lived experience who are all really expert advocates in their own rights. And Lindsay is a member of our Science and Policy Advisory Council, which is our council of scientists and clinicians and public health and public policy focused experts. So I'm going to start briefly by telling you a little bit about my own story and what brought me into advocacy and into starting NPAC, and then turn it over to everyone else so they can tell theirs, and then we can get into a conversation about disability justice, disability rights, and really the importance of sort of centering intersectional voices. So I started in advocacy first professionally as a disability rights attorney right out of law school. I worked in our Department of Justice, which is responsible for enforcing our civil rights laws. And that's basically how we in the United States frame human rights through a civil rights lens. I was in the first office that looked at health rights and disability rights shortly after the Americans with Disabilities Act was in force, which tells you how old I am. But I basically worked there as an attorney litigating cases under the ADA. I was a primary drafter of the current regulations under the Americans with Disabilities Act. And so understanding these issues, and particularly chronic illness issues through a disability lens is pretty natural to me. But I also had an experience personal experience with disability and pain shortly into my career as a civil rights attorney. I was working on a brief one day and I suddenly had really severe pain in my back. My back was burning. It felt sort of like acid was eating my spine. And very quickly, I ended up sort of on the floor of my office when my muscles all started contracting and I had shooting pains down my legs. And pretty much after that, for most of the next 20 years, I was severely limited in my ability to sit at all or to stand still. And I could only walk, very short distances with a mobility aid. So because I couldn't sit, I couldn't have the benefit of using a wheelchair, but I was actually very lucky because I was working in one of the few law offices that would have accommodated me in those days, and was still able to have a fruitful career as a result. And then flash forward many years later, I had a series of surgeries that really restored my mobility. So I was very, very fortunate to have that happen. But after the first of those surgeries, I had moved to Colorado, where I currently reside. And this was in 2015, and I went in to see my doctor for a routine visit. I was taking opioids to manage my pain at the time, and she told me that she was going to stop prescribing to all of her patients effective immediately. And this was concerning to me because I had, taken these medications for many years. And I was finally, for the first time in, 18 years, sort of had the chance to rehabilitate. I was starting to walk again. Things were going well for me. And I thought this would endanger my health. I was lucky because I had a prior treatment team in Washington, D.C. that gave me a taper plan, and I was already going down on the medication when all of this happened. So luckily, there weren't ill consequences for me personally. And the reason that had happened, by the way, for my doctor is that one of our agencies in the United States, the Drug Enforcement Agency, had started really enforcing laws against doctors, and a local doctor had been investigated who was very well respected. And that really did send shockwaves through the community and have a chilling effect on prescribing in my area. So long story short, maybe not short enough, but I was fine, but I saw this coming in the current environment. And then in 2016, after our Centers for Disease Control and Prevention issued guidelines for prescribing opioids for chronic pain, I started hearing through the disability community about the same thing happening again and again and again to a lot of other people. So I got up and started speaking about my experience and writing op-eds and meeting with people who were also joining into this conversation. And then eventually it made sense for us to all come together and form an organization, particularly one that didn't take any pharmaceutical industry funding, because that was a big issue for pain advocacy in the United States. So I will turn it over at this point to, I don't know who wants to go next. Anybody can jump in to tell their story and we can go from there.
All right, I'll go ahead. Thank you so much, Kate, for all the work that you do. As mentioned before, my name is Ola Ojewumi. I'm a disability rights activist here in Washington, D.C. And I have been in pain since I was 9 years old. I was diagnosed with a rare heart condition called hypertrophic cardiomyopathy. And this eventually led to me having a heart and kidney transplant around the age of 11 and 12. Since then, they've never found the root of my pain, but just the reality of having a limited mobility as a result of growing up with a heart condition, and also having a muscular disease called mitochondrial disease. I don't get to stretch my muscles out a lot. I don't get to move a lot, and I'm in constant pain. And becoming disabled at age 9 and having all these health issues, eventually at age 20, I became a wheelchair user, just as a result of the demands of my career. I wanted to work in politics and public policy, but the reality was if I wanted to work on the Hill, I'd have to walk my walking radius would have to be more than a block, which is how far I can walk right now without getting exhausted or tired. And I faced constant barriers and ableism and discrimination based on the fact that I am Black, disabled, and a woman in chronic pain. When I went to treat my pain and sought out services from pain clinics, it didn't matter that I was a public policy fellow at Berkeley. It didn't matter that I had worked in the Obama White House. It didn't matter that I'd worked for Nancy Pelosi. It didn't matter how educated I was. It didn't matter that I went viral sharing my healthcare story with the world. And it didn't matter it had 2 million views. I was still looked at as a drug addict seeking medication to sell or medication to abuse. And you can see this right now, this crisis with chronic pain and disability, with Brittany Griner being held in a Russian prison because she turned to medicinal marijuana to treat her chronic pain. If she was a white, feminine presenting woman, even if she was a white lesbian, she would not be sitting in a Russian prison right now as essentially a political prisoner. My experience in my first pain clinic, my doctor would literally just write the scripts and that was it. All I had to do was come in and they would write the scripts and take my blood pressure. And I began missing appointments simply because of how difficult it was to travel from my home in a wheelchair to his clinic. And essentially, I was discharged for constantly missing appointments. That was the beginning of my journey into conflict with my second and final pain clinic. Essentially, that pain clinic contacted my previous pain clinic and asked why I'd been dismissed. And the person assigned to work my case was a physician's assistant. I went a year without being seen by an actual doctor in that clinic. And anytime I canceled an appointment, I would be reprimanded or treated as though I was abusing drugs recreationally. I was then required to take blood tests every month in order to get this medication, because there are bans on what other types of drugs you could use to treat your pain. So medicinal marijuana was out of the question. Eventually, I had enough. I felt like this was a function of racism because simply I wasn't being treated by a doctor. And the white physician assistant working with me continued to treat me with suspicion. And I felt like my pain was not being believed. So I wrote a Google review and I wrote the facts, which are Black pain patients are less likely to receive opioids and prescriptions to treat their pain because of medical racism and its pervasiveness in this country. We all know about the opioid crisis and how that created all sorts of laws disenfranchising disabled people and chronic pain patients. The reason the opioid crisis didn't touch the Black community is because doctors refused to prescribe it to us because we were already stereotyped as criminals, drug dealers, and drug abusers. I wrote it with passion, I wrote it with anger, and the pain clinic reached out to me and told me to talk to them. I met with a doctor for the first time after that review. I recorded my interaction. He was completely rude and disrespectful. When we talked about addressing my pain, I talked about my stomach, and he said, "I don't care about stomachs." And he implied that I wanted special treatment. I then asked him, "Did you Google me?" before this meeting, because I don't think you know who you're talking to. That was arrogant on my part, but I was feeling like Beyonce that day, and I was like, I'm not having this. I've dealt with enough discrimination for people not to understand that just because you see a Black face in a wheelchair does not mean I'm powerless. So during our second visit, he told me he Googled me and congratulated me on all the good work that I've been doing. But at the same time, they stopped allowing me to take my purse into the bathroom to take these monthly drug tests. Since then, I've given up on pain management. I have no longer used opioids. I literally just live with the pain day in and day out because I'm tired of being treated like a criminal. And thank you for having me, and I'm looking forward to speaking further on this panel.
Thanks, Ola. I would also add to that, unfortunately, the data that is pretty pervasive that shows that at least in the US, providers also would rate the pain of BIPOC people as being less severe because of false ideas about racial differences or racialization of people. So it sort of puts people in a really difficult position coming and going, right, in both directions. There's also the way that we've waged the drug war disproportionately against communities of color that leads to suspicion of drug seeking. So, but thank you for that. Who wants to go next?
I'll go. Thank you, Ola and Kate. This is Charis. My pronouns are they, them. And I am a white presenting person wearing a sort of dark purple sweater, and my background is blurred. I'm also wearing glasses. I, like Ola, have lived with chronic pain since I was a child. I don't know exactly when it started, but I can pinpoint at least age 13, if not earlier. And my diagnosis ended up being axial spondyloarthritis. It's also called ankylosing spondylitis, and it took over 13 years to receive that diagnosis. And part of the reason for the delay is because I was assigned female at birth, and that disease was for a long time, and still is for many people, considered a man's disease, and even beyond that, a white man's disease. So I want to mention that a lot of Black women go decades and decades without receiving a diagnosis for that condition. I was an extremely active kid. My whole life was defined around being active, being an athlete. I played college soccer and I ran marathons, all while living with chronic pain, but not realizing that that's what it was. I had labeled it, oh, I have growing pains. Oh, it's because a doctor told me so. It's because I'm an athlete that I have this low back pain at age 19. That's not a normal age to be told that as an otherwise healthy athlete that you have chronic pain because you're an athlete. But I internalized that, and I lived with that internalized pain until I was 26 and received the diagnosis of axial spondyloarthritis. And my whole world turned upside down. I suddenly lost my identity as an athlete. I was no longer able to work full time. I could no longer volunteer in the community. And it was both pain caused by the disease in my low back, in smaller joints, even in my skin, but also the fatigue that went along with the pain, which is a very common thing. If your body is fighting pain all the time, you're more likely to have fatigue, all of these intersecting symptoms. So I like to share sort of my whole story because my whole story is my story up to advocacy. My advocacy story is my pain story. Because when I was diagnosed and my whole world turned upside down, I desperately needed validation for what I was going through. And so I began posting on social media. I began fundraising for an arthritis organization and sharing my story. But I was sharing my story not for other people, but because I desperately needed people to validate what I was going through. But I quickly realized that sharing my story was helping other people, and it was a way to give other people permission to share their stories with me about what they were experiencing. And I began developing a community around shared experience of pain and of this condition. Within 2 years, I had been featured in an Associated Press article. I had been to Washington, D.C. several times to lobby on Capitol Hill. And I was leading support groups. I was a big name in certain nonprofits with my disease group. And I never planned any of this. I was just catapulted in it just for sharing my story. But 2 years after my diagnosis, I also became aware of the social model of disability, which is loosely, it blames society for being inaccessible rather than blaming disabled people for not being able to do something. And there's some conflict with that, with chronic pain, because that is disabling in itself. But that helped me feel whole again, where my first years of advocacy were solely centered around fighting for a cure so I could feel whole again. After I realized that there could be a whole identity in being disabled and identifying as disabled, it didn't have to be about the cure for me to feel whole again. I realized I could be whole with the diagnosis, with the pain, and I call it being broken and whole at the same time. So, I get a handle on my advocacy. I know all along that I'm queer, but 8 years into my journey with the diagnosis, I realize I'm also transgender. I have 8 years worth of established care with providers who have known me as a woman. And suddenly I'm like, well, how do I come out to a doctor who I'm not sure how they will treat me after I come out? Will I be safe in that environment? So it took at least a year before I felt comfortable even coming out to one doctor, because I was just so scared that I would lose access to care, including pain care, and especially pain care, because I could be labeled as drug seeking if I have, another marginalized identity. But now I'm out to all my doctors, and I'm navigating what it means to navigate care as a disabled trans person, which is more complex than a lot of people who are not trans think it is. I've had doctors say, well, I'm treating your physical pain. What does being trans have to do with it? And a lot of approaching pain care means if you feel safe, you're more likely to trust that provider. And if a provider doesn't respect and see me as a whole person, as a trans person, I'm not going to feel safe with the care that they're recommending. So I think that's a good place to stop and pass it on to Lindsay.
Thanks so much. So hi there, my name is Lindsay Baran. My pronouns are she, her. I'm a white presenting person with, I don't even know what I'm wearing, a teal-ish sweater and curly hair that's half up and some glasses. I, like Charis and Ola, have experienced pain pretty much all of my life, all of my life that I could remember, at least. I started experiencing pain when I was a young girl. I now know that I have Ehlers-Danlos syndrome, but I wasn't diagnosed until my early 30s. So when I was younger, I only knew that I had pain in a lot of places and a lot of other health issues that never seemed to have a clear explanation, and never seemed to really fit together. So when I was in my mid-20s, my pain increased a lot. At that time, I didn't really know anyone else, and certainly no one my age who experienced chronic pain. Around that time, I also had several spinal fusion surgeries, and ultimately neither helped the pain that I was experiencing, even though they helped with some structural issues that had to be fixed. And a bunch of other things that I tried didn't help with that pain either. And by that time, you know, I had experienced the failings of the medical system, both personally and also as the daughter of a disabled father. My dad had MS. And as I mentioned, it took over 3 decades to diagnose my EDS. So I've had a lot of not great experiences with the medical system, which I won't get into right now, but I think coming out of those surgeries, I was feeling particularly hopeless. And that's the point when I realized that I really needed to connect with other people who experienced chronic pain in some way. So I think this was 2010 or 2011, and I remember looking for a support group of some sort. And I live in Chicago, which is a big city with multiple major hospital systems. And I looked at the American Chronic Pain Association and through physical therapist offices, and I looked on Meetup at the time and couldn't find anything at the time. And maybe my searching skills were not great. This could have been, you know, partly to do with me, but I couldn't find any publicly available support groups at the time. So I set up a group on Meetup. And the first meeting, it was me and one other person. The second, it was just me. And I was, you know, like, all right, this failed. This is not going to happen. But slowly more and more people started coming. And after the first few months, we were consistently getting a handful of people at each meeting. And within a couple of years, we had 20 to 30 people showing up at each meeting. And we had close to 200 people in the online group, which was on Facebook. And it was really amazing because this was the first time that I had ever connected with other people with chronic pain. And I was really lucky to have supportive people in my life, but they didn't understand the experience, and they couldn't provide the type of support that I needed all the time. And so, you know, this was the first time that I met other people who really understood really any of the ways that pain impacted my life. They could relate to, you know, the insurance fights that I was having all the time. They could relate to the fear that a doctor was just going to stop treating me, and having to present myself in a very specific way to ensure that they weren't going to change my treatment regimen. And they could, you know, I could talk to them even about like the financial toll that it was taking on me and things that it was sometimes uncomfortable to talk about with other people in my life. And that was really what the group was about, was connecting with other people who could relate and providing peer support to each other. We provided, you know, tangible support and advice on things like applying for disability benefits or workplace accommodations and things like that as well. And it was really just a space for people whose needs weren't being met in some ways to work on supporting each other. So it's interesting because I had been working in the disability community at the time. And I'll be clear that I'd had some breaks in my work and school because of my health, but disability rights had always been my field. But these peer support groups and any pain advocacy I had done had always felt kind of distinctly different and separate to the work that I was doing. And I kind of just always felt the divide between what disability rights or services provided and prioritized and where I fit in with that. And I know that's something that Charis mentioned, and I think that's something we'll be talking about a little bit later as well. So fast forward a little bit, I moved to Washington, D.C. in 2013 and started doing disability policy work at a national disability rights organization, the National Council on Independent Living, or NICL. someone else took over the support group in Chicago, so that actually is still going on. But the job I ended up at was quite demanding, but actually the most flexible and accommodating job that I had ever really experienced. So I had worked only ever at disability organizations in the past, but historically I'd experienced a lot of resistance to the types of accommodations that I needed. And at this job, it was really different from the start. So as a result of that, I felt a lot more comfortable being open about my access needs and my health issues and my pain specifically. And through that, I found that a lot of other people could relate. Even though chronic pain advocacy wasn't really an issue that the mainstream disability rights community was tackling, it affected so many people in the community. So I talked to people who had lost access to their medications and people with pain and substance use disorders who couldn't find a doctor to treat them because they were dealing with both of those. I talked to people who couldn't get coverage for needed treatment. So all of these people weren't connected to the pain community, but were dealing with the issues that we all dealt with and were fighting for. So I approached my boss, our ED, and I made the case that pain is a disability issue and that we should be working on chronic pain advocacy. And it didn't really take too much convincing. Basically, I was told that if I had the capacity to kind of lead the way, I should develop a plan and go for it. And I mean, of course, I didn't have the capacity, but I wasn't going to pass that up. So we started working on it. So we officially launched a chronic pain and opioids task force and pretty quickly got a good core group of chronically ill and disabled people with pain from across the country. Kate joined early on and I somehow managed to convince her to co-chair the group with me. So Kate and I have been working together for quite some time now, even before NPAC. And this was not too long after the CDC's guideline for prescribing opioids and chronic pain was finalized, which was just updated, but that's for another time. And we were already seeing the fallout from that. So that was a big issue that we were starting to work on right away, was trying to preserve access to opioids for folks who needed them. But you know, we had a whole list of priorities and we really got to work right away. So the group did and then still does things like submit comments on proposed rules from federal agencies. We would do direct advocacy at the national or state level, make presentations, develop advocacy materials, send sign-on letters to Congress. There have been a couple of those, each with around 100 organizational sign-ons. And speaking of those sign-on letters, and this is the last point before I wrap up, that kind of leads me to one of the great things about starting this group was that doing this work allowed us to bring more attention to pain issues within the broader disability rights organizations. So we found that a lot of disability rights organizations did care about pain as an issue, but maybe they didn't have the capacity to really dig into these policies or write a set of comments when a new rule or reg came out that they, that was requesting comments. Or maybe it wasn't a priority for them, but they still wanted to show solidarity and support some of the bigger advocacy efforts. And so by starting the task force, we were able to bring more attention to the issues facing the pain community and kind of lead the community in this work. And all of that work then was led by our task force, which was all people who live with pain, and then provide, other organizations an opportunity to get involved with advocacy to the level that they had the capacity to. So I'm going to stop here and I'll pass it back to Kate. So thank you.
Thanks, Lindsay. Yeah, that task force really got us going within, I think, the disability community nationally, and has actually buttressed a lot of the work that we've done at NPAC, where I think we're getting a lot more recognition within the disability community, including funding from the Disability Project at the Ford Foundation, which is great. So we also at NPAC have joined a collaborative of a group of disability rights organizations working for economic justice. And so we've sort of been working on coalition building, but a lot of that did start with the work that Lindsay started at Nickel, which is terrific. So I also had a strange experience with pain versus disability. My office was wonderful in accommodating me. I had a terrific boss at DOJ, but here we were writing regulations, and there were no regulations for people who had to lie down. We were, I was just in a disability office, a real oddity. So I think there's still a lot that needs to be integrated in sort of understanding of the unique needs that people with pain present in terms of accessibility needs. And we're hoping to continue to run with that. But I wanted to pick up on the sort of disability thread because I know we've all worked in disability and with chronic illness organizations and with sort of integrating those. So I wanted to maybe start with Charis, because I know that you worked a lot starting through chronic illness organizations and then sort of came to an awareness of disability, to talk about that. And then maybe Lindsay can talk a little bit about the difference between the sort of disability justice and rights frame. And Ola can talk a little bit about also the importance of sort of, looking at it through a disability lens, but also a racial justice lens, which is a really important lens as well. So, Charis?
Thank you, Kate. Put me on the spot here. Yeah, when I first started my advocacy journey, it was with disease-specific nonprofits. I worked a lot with the Arthritis Foundation and the Spondylitis Association of America. And I did a lot of fundraising for the Arthritis Foundation. I was featured as one of their fundraising walk honorees early on. I did a lot with Spondylitis Association recently with a policy proposal for declaring spondyloarthritis I forget what the word is. Kate, help me here.
Isn't it for a month or an awareness?
Yeah,
Yeah,
thank you.
Sure.
Declaring it an awareness month in May. So I've done a lot across the board with disease-specific organizations, and I still do. But after I realized that I was disabled, and after I learned about the social model of disability and claimed disability as one of my identities, I realized that there is a really harsh divide between a lot of chronic disease advocacy and a lot of disability advocacy. So, I mean, chronic disease is a disability that is indistinguishable. And a lot of chronic diseases involve pain. But my advocacy with chronic disease groups was focused on, finding the cure, finding good treatments, all of which is awesome work. But it was also, there was also a lot of pressure to focus solely on successes and overcoming the disease and doing things despite the disease, and not identifying as disabled and trying to work as long as you can and not using mobility aids because then you would be seen as disabled. And it's the exact opposite in disability justice world, which I now sort of center my efforts in and try to bring those ideals back to chronic disease advocacy with me, with combating both internalized and external ableism. I lost my train of thought. But I think it was really hard when I didn't realize that disability justice was a thing that I needed in my life, to solely focus my efforts on gaslighting myself for not being able to ignore the pain or do enough to fix my mobility or do enough to not use a wheelchair. And denying myself those things increased my symptoms, increased my pain, increased my fatigue, and my whole life changed for the better once I claimed the disability identity. So I think that there's a lot of important discussion to be had to connect the two communities that have no business being separate at all, and wrapping disability justice principles and frameworks into all chronic disease specific advocacy, so that we are helping people who are newly diagnosed, especially in this new era of long COVID, where maybe a majority of the world will become disabled, where we hurry up and help the chronic disease community feel whole immediately after being diagnosed, rather than forcing them to gaslight and internalize the ableism. Yeah, so I want us to bridge that gap somehow.
Thank you, Charis, and thank you for mentioning long COVID, which is, of course, a very important, addition, because pain is a primary feature also of long COVID as well. Lindsay, do you want to talk a little bit about the difference between sort of a rights and justice framework for disability?
Sure. Yeah, I can. I'm happy to get us started, and I would love for anyone else to chime in who has additional thoughts and information. And I'm going to put some information in the chat as well. So I think, kind of broadly speaking, the way I would look at rights versus justice is that, rights is an approach towards fighting discrimination that focuses on kind of laws and policy. Primarily, right? And then disability justice recognizes that rights through this frame, through laws and policies, can only be claimed by people with a certain amount of privilege and power. So it focuses on addressing the root causes of inequities instead, not necessarily in place of laws and policies and saying that laws and policies have no place, but that we need to get to the root causes of inequities, and that laws and policies are not enough. And then disability justice focuses on leadership by the most impacted. And the people who are most impacted are often not in a place of power and privilege to claim rights, even when laws and policies are on the books, right? So you think about the Americans with Disabilities Act, we have that law, but just because it's a law doesn't mean that all disabled people have all of our rights enforced, right? And the people who are least likely to have their rights enforced are the folks who are most marginalized. And so the organizations that I was referring to before, like the organization I worked for, the National Council on Independent Living, and a lot of the mainstream organizations that we worked with are primarily disability rights organizations. Those tend to be the most resourced organizations, the most funded organizations. A lot of organizations are now starting to use the term disability justice when the work is still disability rights focused. And then there are some really great organizations and people doing disability justice work. So I think we wanted to kind of just bring those two concepts up to make it clear that there is a distinction. There's an organization called Sins Invalid that has a definition of disability justice that I think is worth sharing. So I'm going to put that in the chat, but I'd also really welcome anyone else's input if you have any other thoughts on the distinction between rights and justice.
Sure. I mean, I think it's important to sort of somehow embrace both lenses, because we need, Arsenal to make change. But I will say, as someone who worked enforcing the ADA in the early days of the ADA, it was so clear that the people who were most privileged were the first to get through the door and enforce their rights. I mean, my first case was, about accommodations for CPA students who were deaf, right? Or law students who were taking the LSAT needed accommodations. It was really the people who were already knowledgeable about their rights, already privileged, whose sort of rights were being effectuated. And that, has continued to be an issue, I would say, within the larger community. Well, I want to turn it over to you for your thoughts on this, not to, again, sort of pounce, but love to hear your thoughts.
Oh, well, I will just say my work in specific focuses on the intersection of race and disability when it comes to chronic pain. So some of the work that I do is specifically within public policy. So I've testified about prescription drugs before Congress. I've testified before Congress, before the House and Ways Committee. And I've also used the written word to talk about my personal experience and challenge others to effectively vocalize their racist experiences within doctors' offices, and not to continue to be silent. I also do a lot of speaking to doctors and speaking to patient advocates and challenging them to interrogate their unconscious biases. As I mentioned the incident with my pain management doctor, when I mentioned racism in my Google review, they effectively went and hired a Black doctor. And he was essentially assigned to work with me. And I told him everything that happened. I told him, this is partially, a hire due to kind of remedy my complaints about a lack of diversity here. And he was there temporarily and eventually left after I told him. And then they assigned a nurse practitioner to work with me, who never even knew that I was a heart transplant and kidney transplant patient. She had to notice my scar on my chest for her to even say something. They just, how do I say this? This is not the perfect example of how to use your voice. Well, it's not a perfect example of how using your voice affects change, even if it's only temporary. But what could happen if white disabled people and white chronic pain patients did what I did times 10? And so I use my platforms on social media to advocate that if you see something, say something. And also, if you're a physician, study how your habits affect your Black and brown patients. Essentially, I'll give you an experience. When I had my heart and kidney transplant, 1 week after, I was still in the hospital, and in response to my pain, they told me to take a Tylenol. White kids who go to the dentist's office get better pain management than me, who was cut open in 2 different places. The surgeries, my heart and kidney transplant, were 5 hours apart. And that at age 11, that was the first time I really noticed systemic racism, because my transplants happened at Children's Hospital of Pittsburgh. And of course, it was a majority white hospital. And we saw how white transplant patients were treated, as opposed to the few people of color. I mean, to be honest, I think I was the only Black person on the floor. And they even refused to learn my name. They were calling me Double O because my name is Ola Ojewumi. That's my full name. But even the acknowledgement of calling me my name, they would call me Double O for short, instead of calling me my name and learning to pronounce it. And those profound experiences of medical racism aren't shared enough. And also the perfect victims. I want to get rid of the narrative that, how do I say this? That in order for people of color and Black people to vocalize their anger with the system and injustice, that they have to be perfect victims, are essentially perfect, not victims, but I should say people who don't have criminal records, people who, may have, I don't even know what to say. So for example, we have a lot of ableism in terms of people who are accused of causing their own disabilities. And this is in part due to racial stereotypes about Black women, you know, obesity, high blood pressure, strokes, that you became disabled from your own, you know, volition and actions. Therefore, you don't deserve empathy, and you don't deserve to complain about chronic pain or being mistreated by pain physicians or the medical system. So I want to abandon that narrative of poverty means disabled Black people shouldn't be able to vocalize their concerns. That, you know, if you're a Black person with a criminal record, you shouldn't be, you know, able to represent the disabled community in advocacy for chronic pain. I want to demolish all the racial stereotypes and allow for the face of disability rights with respect to chronic pain to be those who are considered the untouchables, those who are forgotten, and those who are traditionally excluded. I feel like it's terrible that the majority of people speaking on this tend to be educated, tend to be, you know, financially stable, and tend to be privileged. I include myself in that category as a college educated woman, you know, as someone who has a stable job, good health insurance. I can do these things, but why aren't, you know, why are the traditional leaders, you know, people who don't look like the victims of medical racism, you know? So thank you. Any questions?
Absolutely, 100%. 100%. And I think we're all, you know, at various degrees of privilege, but, you know, part of it is sort of having basic needs met and being able to then go out and advocate. But it means that we really do need to be reaching out at every opportunity.
Very true.
Yeah. Grace, do you want to?
I have a lot of thoughts. Not all of them are on topic, so I can wait for that. But I have a question for us all. I guess it's more of a prompt for discussion just because I'm curious. Would it be accurate to tie rights to law/policy, as we've discussed, and tie justice to systemic disruption?
I think that's an interesting way of framing it. I mean, I certainly think that, you know, rights tied to laws and policy is pretty clear, and has its downfalls too, not just in terms of who's included and who isn't, but even, you know, how we create stigma. Oftentimes when we separate people out through laws, we end up othering and stigmatizing. And so there are, you know, the essentialization through medicalization, but also through sort of the legal process can create further barriers. I think justice, I think justice, because it looks at, you know, the systemic problems or the social model problems broadly, not just in terms of disability, but in terms of poverty and race and all of these other things, is going to look to its solution as social disruption. Yeah, I think that's fair, definitely. Anybody else have a thought about that?
I think I definitely see that. I guess depending on how broad like disruption is defined would be my question, because I think I see like, you know, mutual aid and things like that as fitting into disability justice as well. And that's like disrupting the traditional ways of like how we do things, but it's not disruption in the terms of like trying to like dismantle the system, you know what I mean? So I think like how we define disruption would change my answer, but I think broadly I see that like alignment as yes. Sorry, that was not an answer that made sense.
It definitely made sense. So I'm noticing that there's a comment in the Q&A for Ola. This person says, as a brown, non-perfect woman with many complex chronic diseases, I unfortunately related to this so much. Even with a Bachelor of Science in Molecular Biology and Biochemistry, I started to get more attention with when my white husband would speak up on my behalf. I've heard that before.
that is definitely an example of medical racism. And I'll say this, as the child of immigrants, I would notice how people would talk down to my mother because my illnesses began in childhood. And since she has an accent, they did not treat her as though she was intelligent. So it's all everybody,
Yeah, I mean, another person in our group, Kiana Madison, actually who's African-American, had the police called on her when she went to the emergency room once, reporting pain. And she says, it's a good thing my boyfriend was white because he was able to talk me out of being carted out of there. So, the racism is alive and well, for sure. It's undeniable. Other thoughts? It looks like we've got about 4 minutes left. I don't know if people have questions who are listening, or if there's anything we didn't quite get to. I've really enjoyed the conversation. I always like listening to all of you.
I don't see any questions, so I just want to jump in and add one thought that I think a lot of people don't think about who are even doing diversity, equity, and inclusion work, that we often leave the A off the end of that acronym for accessibility. And in DEI justice work, it is vital to include the A because pain is the leading cause of disability, and accessibility is a huge, it expands all marginalized identities. Every group of people has disabled people in it. Everyone is likely to become disabled if they live long enough, and if we are not including disability justice, i.e. accessibility, in DEI work, it's not going to be successful.
I think that's a perfect way to conclude our conversation. So thank you again. Thank you to everyone for listening. And I guess it's time for us to bring Chris back in.
Thank you so much, Kate, Ola, Charis, and Lindsay, for an incredibly important discussion. I've been to many pain conferences over the years, and I always come away feeling the same, which is, aside from all the incredibly valuable information that's translated, to me, it's like the willingness of people to share their very personal stories of life with pain that's had the biggest impact on me. And it always feels like coming home to family in many ways. And the purpose of this entire conference is to build community, and it feels like you guys have really been successful at doing that yourselves. So thank you very much for sharing. We are finished for the day. We'd like to thank all those who participated as speakers and as attendees in today's sessions, and hope you enjoyed the sessions, the gentle movement, water cooler breaks, whatever you did. And we hope you'll join us tomorrow for sessions that start at 2 p.m. Eastern Standard Time and run to 5 o'clock Eastern Standard Time. Format will be pretty much the same: 2 hours of programming, 1 hour of break, gentle movement, water cooler discussion in between. So thanks, everybody, and we'll see you tomorrow.